Hello everyone and welcome to our module on shock. Shock is a life-threatening fall in blood pressure that leads to poor tissue perfusion, and if not treated promptly, it can potentially lead to death. And there are basically two mechanisms by which shock can develop. Recall that your blood pressure is dependent on your cardiac output and your total peripheral resistance. So the way that you can develop shock and a life-threatening fall in blood pressure is if either the cardiac output or peripheral resistance are low. Now, there are two reasons why you can develop low cardiac output. First of all, it could be a problem with the heart itself and a loss of cardiac contractility. And the second reason you can have a low cardiac output is if there's low intravascular volume. If the intravascular volume is very low, even if the heart is pumping normally, the cardiac output will fall. And then, of course, you can also have shock from peripheral vasodilation. This leads to a fall in the peripheral resistance. Shown on this slide are the four major causes of shock. The first type is cardiogenic. This is a cardiac disorder that leads to a fall in cardiac output. So for example, patients with massive myocardial infarctions often develop cardiogenic shock. The problem is a loss of contractility and a fall in cardiac output. Second type of shock is hypovolemic. This is when there's a fall in intravascular volume. This also leads to a fall in cardiac output, but for a different reason than cardiogenic shock. And the classic example of hypovolemic shock is a patient with a massive hemorrhage. That patient will have low intravascular volume and a low cardiac output. The third type of shock is called distributive. This is the type of shock seen when there's massive peripheral vasodilation. There are many subtypes of distributive shock, but you may be familiar with septic shock. This is when an infection leads to peripheral vasodilation. Anaphylactic shock is also a type of distributive. That's when an allergic reaction causes shock. And then the fourth type of shock is called obstructive. We'll talk about this later. This is really a special type of shock where something is obstructing the outflow of blood from the heart. When a patient has low blood pressure and shock, it's important to figure out the type of shock. And the reason is because different treatments are effective for the different types of shock. Now, in clinical practice, we often know the type of shock just from the history. For example, a patient who had a myocardial infarction who develops hypotension obviously has cardiogenic shock in most cases. A patient with massive bleeding usually has hypovolemic shock. But when a patient has shock and we don't know why, there is a test that we can do to get some more details on the type of shock and potentially figure out the cause of shock. And that test is called use of a Swan-Ganz catheter. A Swan-Ganz catheter is named for the two men who developed it. It's also sometimes called a pulmonary artery catheter. And this is a catheter where the sensor at the tip measures the pressure, and it can be inserted into the heart to measure the pressures in the heart. So shown here is a drawing of the heart. This is the right atrium. This is the right ventricle down here. This is the pulmonary artery right here. And so as we move the catheter through these chambers, we can stop in each chamber and take a measurement of the RA pressure, the RV pressure, and the PA pressure. We can then do something special called wedging the catheter. To do this, you inflate a balloon at the tip of the catheter and you wedge the catheter into one of the pulmonary arteries. At this point, the tip will be beyond the balloon and it will be sensing the pressure beyond the obstructed flow by the balloon. And the pressure beyond that obstructed flow is the pressure in the left atrium. Beyond this obstruction here in the pulmonary artery, we are seeing backflow from the left atrium, so we will be sensing the left atrial pressure. So when you use a pulmonary artery catheter and you wedge it, you measure what's known as the pulmonary capillary wedge pressure, and this is essentially equal to the left atrial pressure. So what this means is that by using the Swan-Ganz catheter, we can measure the pressure in the right atrium, right ventricle, pulmonary artery, and left atrium. And using those four pressures, we can often determine the cause of shock. So shown on the screen here are the data that you can get from a Swan-Ganz catheter. As I said before, you can measure the RA pressure, normal is about 5. You can also measure the RV pressure, normal is about 20/5. You can measure the PA pressure, normal is about 20/10. And then you can measure the wedge pressure, and normal is about 10. You can also take a blood sample from the pulmonary artery. This is called a mixed venous oxygen sample, and measure the mixed venous oxygen saturation or the mixed venous oxygen concentration. This is the concentration of oxygen after all the veins in the body have mixed together in the right ventricle. And as we'll see in a minute, you can use this value with the Fick equation to determine the cardiac output. The Fick equation is an equation that can be used to determine the cardiac output together with data from the Swan-Ganz catheter. The Fick equation is based on the principle that oxygen consumed by the body must equal the oxygen that leaves the lungs after the blood has been fully oxygenated minus the oxygen returned to the lungs in the venous blood. We can then say that the right side of this equation is also equal to the cardiac output times the arterial oxygen concentration minus the venous oxygen concentration. If we rearrange this equation and solve for the cardiac output, we get the Fick equation, which says that cardiac output is equal to O2 consumption by the body divided by arterial oxygen content minus venous oxygen content. And it turns out that all these variables are easy to obtain if you use the Swan-Ganz catheter and other measurements from the patient. A patient's oxygen consumption is proportional to their body size. You can look this up from reference tables. The arterial oxygen content can be determined from an arterial blood gas or by measuring the O2 saturation on the finger probe together with the hemoglobin. And then the venous oxygen content, as I told you on the last slide, can be determined from that mixed venous oxygen sample obtained from the Swan-Ganz catheter. So if we obtain this single mixed venous oxygen saturation, these other variables are easy to get. We can plug them all into the Fick equation, and now we get the cardiac output. So what this means is that in addition to the pressures in the heart, the Swan-Ganz catheter also gives us the cardiac output, which is very helpful for determining the etiology of shock. And once you know the cardiac output, you can determine the systemic vascular resistance with the Swan-Ganz catheter. So in the video on blood flow mechanics, I talk about the flow equation, and the flow equation says the change in pressure as blood moves through the body is equal to the cardiac output times the systemic vascular resistance. Systemic vascular resistance is the same thing as total peripheral resistance, or TPR. We can then say that the change in pressure as blood moves through the body is equal to the mean arterial pressure minus the right atrial pressure. Because blood leaves the heart and goes into a system where it has the mean arterial pressure, blood that returns to the heart has the right atrial pressure. If we rearrange this equation here and solve for the SVR, we get that the SVR is equal to the mean arterial pressure minus the right atrial pressure over the cardiac output. Well, I told you that the Swan-Ganz catheter can measure the right atrial pressure. I also told you that it can determine the cardiac output, and the mean arterial pressure we can get just from taking the patient's blood pressure. So this means that the Swan-Ganz catheter, in addition to all the things I've already talked about, also gives us the systemic vascular resistance. So on this slide are all the measurements we can obtain from the Swan-Ganz catheter. We can directly measure the pressures in the right atrium, right ventricle, pulmonary artery, and the wedge pressure, which is equal to the left atrial pressure. We can also directly measure the mixed venous oxygen content, or saturation. From these numbers here, we can then calculate the cardiac output and systemic vascular resistance. So basically, the Swan-Ganz catheter gives us a complete hemodynamic picture of the patient, and that hemodynamic picture can be used to determine the type of shock if it's not obvious from the patient's history. So now that we understand how the Swan-Ganz catheter is used to determine hemodynamics like filling pressures and the cardiac output, let's talk about how you use those hemodynamics to make a diagnosis of the cause of shock. So there are four major classes of shock, and they all have different hemodynamics as measured with a Swan-Ganz catheter. So in other words, you can use the Swan-Ganz catheter to determine the etiology of shock if it's not apparent from the physical exam and the clinical history. And the four major types of shock are cardiogenic, hypovolemic, distributive, and obstructive, and we'll talk about all of these in the next few slides. Let's first talk about cardiogenic shock. So the hallmark of cardiogenic shock is a low cardiac output with high cardiac filling pressures. These two findings are what happens when the left ventricle is not working, such as in cases of a large myocardial infarction or advanced heart failure with a severely depressed left ventricular ejection fraction. In these cases, the cardiac output gets very low. The chambers in the heart fill with blood volume and they will have high pressures, and in addition, the systemic vascular resistance will be high. This is part of the sympathetic nervous system response to low cardiac output. Remember, anytime you have shock and you have low blood pressure, you should have a high SVR. That's the body's normal response, and therefore in most forms of shock you have a high SVR. The one exception is distributive shock, which we'll talk about in a minute. Hypovolemic shock, like the name implies, occurs when there is low volume. So this can occur in patients who have very poor fluid intake, especially if they also have GI losses like nausea, vomiting, and diarrhea. It can occur in the setting of high fever where patients have insensible losses in their lungs. It can also be seen in the setting of hemorrhage. When there is low intravascular volume, there will be a low cardiac output, just like in cardiogenic shock. But the difference is, in hypovolemic shock, the cardiac pressures are low. In contrast, as we talked about in the last slide, in cardiogenic shock, the cardiac pressures are high. And then once again, in hypovolemic shock, just like in cardiogenic shock, the SVR is high. This is the normal sympathetic nervous system response to low tissue perfusion. The body is clamping down on arterioles, raising the SVR, trying to maintain tissue perfusion in the setting of low cardiac output and low cardiac pressures. Distributive shock gets its name because of an abnormal distribution of blood volume. So there's a normal amount of blood volume in the body, but it's distributed to the tissues and it's not held inside the blood vessels. The hallmark of distributive shock is low SVR. This is the only type of shock that has low SVR. If you read a board question and it describes low systemic vascular resistance and they ask you the type of shock, they're always talking about distributive shock. In distributive shock, there is diffuse vasodilation or endothelial dysfunction, and you can basically think of this as a process where fluid leaks out of the vascular space and into tissue beds. The classic and most common cause of distributive shock is septic shock or sepsis, but you can also see distributive shock in patients who have anaphylaxis and are having an allergic reaction. You can also see it in patients who have severe neurologic damage, like a massive intracerebral bleed. They can develop what's known as neurogenic shock, where the blood vessels become leaky and distributive shock occurs. In distributive shock, as I said, the main feature is low SVR, but what about cardiac output and filling pressures? Well, classically, cardiac output is high. That's because when you lower the vascular resistance, you're reducing the afterload in the left ventricle, and therefore the cardiac output should go up. Now, in real life, the cardiac output is highly variable and it's not always high, but in board questions, it will usually be high. And just like cardiac output is often variable, the cardiac pressures are often variable depending on many factors. For example, in sepsis, patients can have fever and therefore they can lose blood volume and that can lower the cardiac pressures. However, they are also usually treated with normal saline when they have septic shock, and that can raise the cardiac pressures. So basically, in terms of distributive shock, what you just want to remember is that the SVR will be low, the cardiac output and cardiac filling pressures are often variable. We'll talk about obstructive shock in a minute, but it's a very unusual form of shock, sort of in a class by itself. On this table, I've summarized the three major types of shock: cardiogenic, hypovolemic, and distributive, and I've listed their main hemodynamic features. So in all three forms of shock, the blood pressure is low and the heart rate is high. That's common to all forms of shock. What's different between the forms of shock are the pressures in the heart, the cardiac output, and the SVR. So let's talk about cardiogenic first. So in cardiogenic, the cardiac output is low, and the pressures in the heart are all high, as shown here in this table, and the SVR is high as part of the normal sympathetic response. In hypovolemic shock, the cardiac output is also low and the SVR is also high, but in contrast to cardiogenic shock, the pressures in the heart are all reduced. And then finally, in distributive shock, remember what I said, the hallmark is low SVR. The cardiac output is classically elevated and the filling pressures are variable. They may be low or normal, or in rare cases, they can even be elevated. And here's a little flow diagram to help you understand how to diagnose the major forms of shock. So when you're faced with a board question and they give you hemodynamics and ask you what type of shock is occurring, first of all, look at the SVR. If the SVR is low, then you know you've got a case of distributive shock. If the SVR is high, then you next want to look at the pressures in the heart, like the wedge pressure and the right atrial pressure. If those pressures are high, then you're probably dealing with cardiogenic shock and the cardiac output should be low. If those pressures are low, then you're probably dealing with hypovolemic shock and the cardiac output is also low in hypovolemic shock. Sometimes in board questions, they will describe the physical exam of a patient in shock and ask you to use physical exam clues to infer the type of shock. So let's talk about that now. So if they tell you a patient has cold skin, this is what is classically seen when there's high vascular resistance and low cardiac output. If you have high vascular resistance, this means arterioles are clamped down, and if on top of that the cardiac output is low, you will have very poor perfusion of the skin, especially in the hands, which are far away from the heart. So patients can have cold skin, especially of the hands, when there is a high SVR and a low cardiac output, and that's seen in cardiogenic shock and hypovolemic shock. If they tell you the skin is warm or even flushed, this is what's classically seen when there's a low vascular resistance and a high cardiac output, like in distributive shock. In this scenario, you have very little resistance to flow and a high cardiac output coming from the heart, so the skin can be warm and flushed. They may also give you physical exam findings from which you can infer the pressures in the heart. So elevated jugular venous pressure means there's high right atrial pressure. Remember that that's seen in cardiogenic shock. And pulmonary rales are an indication of high left atrial pressure, and that is also seen in cardiogenic shock. Obstructive shock gets its name because in this form of shock there is obstruction to blood flow from the heart. These patients will have a low cardiac output just like cardiogenic shock, but they have normal left ventricular contractility. So this occurs in a couple of unique settings where the heart can't pump blood to the body even though the heart itself is normal. So in tamponade, the left and right ventricles are completely normal, but because there is fluid surrounding the heart, the cardiac output falls. In a tension pneumothorax, the same physiology as tamponade occurs. There's very very high pressure inside the thorax. This impairs the ability of the heart to fill, and therefore the cardiac output falls, even though the heart muscle tissue is working normally. Also, in a massive pulmonary embolism, there can be poor blood flow from the right ventricle to the left, and this can drop cardiac output. So obstructive shock looks just like cardiogenic shock. There's a low cardiac output and high SVR. The difference between obstructive shock and cardiogenic shock is that in obstructive shock, the ventricles are working normally. And these forms of shock are usually diagnosed by some type of imaging that shows fluid around the heart or pneumothorax or a pulmonary embolism. They are usually not diagnosed by hemodynamic data from the Swan-Ganz catheter. The reason it's so important to determine the type of shock in a patient is because the treatments are different for all the major categories of shock. In cardiogenic shock, the primary problem is a fall in contractility, so the treatment is with inotropes, which are drugs that increase contractility. These are drugs like milrinone and dobutamine. In hypovolemic shock, the treatment is to add volume. This could be through blood transfusions or IV fluids. In distributive shock, the primary problem is vasodilation, so the treatment is with vasopressors, which are drugs that cause vasoconstriction. These are drugs like phenylephrine and epinephrine and norepinephrine. And then finally, in obstructive shock, the treatment is to relieve the obstruction. So you treat the tamponade by removing fluid from the pericardium, or you treat the pulmonary embolism, or you resolve the tension pneumothorax. Doing all of these actions will resolve the cause of obstructive shock. For the last few slides of this video, I will talk about how you can use the Swan-Ganz catheter in valve disease. This often comes up on step 1. You're shown the cardiac hemodynamics from a patient and asked to identify the cause of valvular heart disease. So let's go through that now. On this table, I've listed the normal pressures on the left side of the table. So in the right atrium, the normal pressure is 5. I've also shown the normal pressures for the right ventricle, the PA, the wedge pressure, the left ventricle, and the aorta. On the right side of the screen are the hemodynamics from a patient with valvular heart disease, and let's see if we can figure out what the heart problem is. So this patient has an increased right atrial pressure of 15. The right ventricular pressure is also high at 45/15. The pulmonary artery pressure is increased, and the wedge pressure is increased. However, when we get to the left ventricle, we then find that the left ventricular systolic pressure is normal, and the left ventricular diastolic pressure is actually low at 5. Look over at the normal values. Normally the wedge pressure, which is a marker of left atrial pressure, should be nearly identical to the left ventricular end diastolic pressure. That's because in diastole, the wedge pressure, which is the left atrium, has the same pressure as the left ventricle. So the diastolic pressure in the left ventricle should be the same as the wedge pressure. In this patient, however, what we have is a big gradient in diastole between the left atrium pressure represented by the wedge and the left ventricular diastolic pressure. And the condition that causes this problem is mitral stenosis. So this patient does not have the same wedge pressure as the LV diastolic pressure. That means there's some obstruction of flow between the left atrium and the left ventricle in diastole, and the only valvular condition that causes that is mitral stenosis. And then once the pulmonary wedge pressure rises, all the pressures back up behind that level of the heart. So we see high pressures in the pulmonary artery, the RV, and the RA. This is all backup of blood behind the left atrium, which is filled with blood because of mitral stenosis. Now let's look at another case. Here we have a patient with a normal RA pressure, normal RV pressure, normal pressure in the PA, and normal wedge pressure. However, when we get to the left ventricle, the diastolic pressure is normal, but the systolic pressure is increased. In addition, the systolic pressure in the left ventricle of 150 is not equal to the systolic pressure in the aorta of 120. This should never happen except when you have aortic stenosis. So normally the LV systolic pressure and aortic pressure are roughly the same because it takes very little pressure difference to open the aortic valve. In this patient, we've got a big gradient of 30 millimeters between the left ventricle in systole and the aorta in systole, and that's because there is obstruction to flow across the aortic valve. Another way to think about this is the pressure in the left ventricle has to get much higher than the pressure in the aorta in order for the aortic valve to open and blood begin to flow into the aorta. Here's another case. We've got high pressure in the right atrium, in the right ventricle, in the pulmonary artery, in the pulmonary capillary wedge pressure, meaning the left atrium. In the LV, we've also got elevated diastolic pressure, and what we've got in the aorta is a very low diastolic pressure in the aorta. And if you notice, the difference between the systolic and diastolic pressure in the aorta, which is the pulse pressure, is markedly increased in this patient. And anytime you see high pulse pressure in a patient with valvular heart disease, you should think of aortic regurgitation. In aortic regurgitation, blood leaks backward across the aortic valve into the ventricle. This causes the diastolic pressure in the aorta and in the systemic vessels to get very low, and therefore the pulse pressure goes high. In addition, because blood's leaking back into the left ventricle, the left ventricular diastolic pressure rises, and that leads to high pressures in all the chambers that come before the left ventricle. In the video on venous pressure tracings, I talked about how you could take a pressure catheter like the Swan-Ganz catheter and measure the pressure in the right atrium, and you would see a pressure tracing that looks like this. So in this video, I told you that a normal right atrial pressure is 5, but the reality is that if this were 5, the pressure actually bumps up a little bit above 5 in some instances and a little bit below 5 in other parts of the cardiac cycle. And the typical pattern that the right atrial pressure demonstrates when it bounces up and down throughout the cardiac cycle is to have an A wave and a C wave and a V wave and an X descent and a Y descent. And I talk about all these things in a venous pressure tracing video. But you should be aware that the left atrium has the same pressure tracing. The average pressure is a little bit higher in the left atrium, but in the left atrium there is also an A wave and a C wave and a V wave and an X descent and a Y descent, the same pattern of the waves as you see in the right atrium and in the systemic veins. And you can actually see this tracing if you wedge the pulmonary artery catheter. You will then see a little bump for an A wave, another bump for the V wave in the left atrial pressure tracing. And because you can see the A, C, and V waves of the left atrium using the Swan-Ganz catheter, you can find giant V waves in that tracing in mitral regurgitation. This is just like the giant V waves that you get in the right atrial pressure tracing in patients with tricuspid regurgitation. In this case, we're talking about the left side of the heart, so it's mitral regurgitation that causes the giant V waves. And these are a classic finding in patients with mitral regurgitation on hemodynamic testing with the Swan-Ganz catheter. They are similar to the giant V waves in tricuspid regurgitation seen in the venous pressure tracing. And that concludes our video on shock.